the thyroid. And I have subtitled it a continuing conundrum. Does any one of the students know what is the meaning of the word conundrum? Let me ask Aditya. He's the senior most over here. Aditya, what is the meaning of the word conundrum?
Ma'am, can I take a humble guess?
Sorry?
Can I just take a humble guess, ma'am?
A humble guess? Yes, you can take a guess. Why does it have to be humble?
Ma'am, evolution with time, something related to evolution with time, ma'am.
Evolution with time. No, Aditya, it isn't that.
Okay.
All right, let's ask the next most senior person over there, Swati. What is the meaning of the word conundrum?
Something which is confusing.
That is confusing. Absolutely right. Yes, you're right, Swati. It means something that doesn't have a straightforward answer. Okay, so that you are right. It's confusing. It may be a difficult problem. It may be a problem, whatever it is. That is the meaning of the word conundrum. And the word continuing conundrum means that there are so many different changes that have taken place when we are looking at something that is supposedly as simple as an encapsulated follicular patterned lesion in the thyroid, that you should wonder why then should anything be confusing. Let me just start by asking some of these questions to the students over here, so that I get a basic idea of what the students understand. Because I know one thing, that you students are standing in place of all the other students who are in the audience, and you are a sample of the entire student community that is listening to this talk. So if you have problems or you have questions, then these are the problems and questions that perhaps all of the other students have in some form or the other. All right, so let me now ask someone who's probably the junior most, Diksha. You're from Bhilwara, right, Diksha?
Yes, ma'am.
Are you there? Can you hear me?
Yes,
Yeah,
ma'am.
okay. Good. Will you like to take the first question there? Can you name some common thyroid tumors? I'm sure you've heard of some common thyroid tumors. Yes?
Nodular goiters,
Nodular goiter is not a tumor, Diksha.
follicular adenoma,
All right, you've heard of follicular adenoma. Anything else you've heard of? No. Have you seen any thyroid tumor at all?
yes, ma'am.
Yes, very good. So what thyroid tumor have you seen?
Oncocytic adenoma, Hurthle cell adenoma.
Hurthle cell adenoma. Okay.
It was
You heard of
reported.
any other? No? You heard of follicular adenoma and you heard of you
Medullary
saw
carcinoma,
medullary
papillary thyroid
thyroid
carcinoma,
carcinoma. Very good. Anything else?
anaplastic
Anaplastic
carcinomas.
thyroid carcinoma. All right. Did you ever hear of no? Okay, you haven't heard of it. Okay.
Yes, ma'am.
Let's go to Deepak. Deepak?
Yes, ma'am.
See, we're talking about follicular patterned lesions, yes? Encapsulated follicular patterned lesion. So what do you understand by a follicular patterned lesion?
Follicular pattern lesion mainly is those type of lesion which have architecture or pattern is follicular type.
Is
It may
of
be
follicular
either-
type. Okay, that's very good, Deepak. It is a follicular type. So can you explain what is a follicular type pattern? What is a
type-
follicle?
Follicle means cells are arranged in a ring fashion which covers some spaces containing a colloid.
Okay, so that is what you understand by follicle. Now, suppose I ask you, Deepak, there are follicles in the lymph node, yes?
Yes, ma'am.
So is that a follicular pattern?
No, ma'am.
It's not. So you don't have a follicular pattern in a lymph node, Deepak?
Yes, ma'am. There is also
So then what is a follicle? So then what is a follicle, Deepak?
Cells, follicle means cells are arranged in a ring-like fashion.
But they're not arranged in a ring-like fashion in a lymph node, are they, Deepak?
Yes, ma'am. They are filled up with cells.
So what do you think is a follicular pattern? Doesn't matter, we have to learn. So if you think it's ring-like because you are comparing it with the thyroid, yes? Do you know any other place besides the lymph node and the thyroid that has follicles? Yes?
Follicles literally mean cells are some group of cells are aggregated.
Some group of cells. Do you know any other place where you see follicles, Deepak? You told me thyroid, yes, and I asked you about lymph node. Are there any other places where you see follicles? No? Okay, let us ask Daksha. Daksha, any other place that you see follicles?
Ovarian.
Ovarian, very good. Who said that?
Yes, ma'am. Deepak, yes, ma'am.
Yes. So there's an ovarian follicle.
Ovarian follicle.
Excellent. Fair enough. Okay. Any other place, Daksha? You know follicles?
Skin.
Sorry?
Skin.
Skin. You're very good. What is that follicle that you see in the skin? What follicle do you see in the skin?
Hair follicle.
Hair follicle.
Hair follicle.
So now I'm asking Deepak, you have lymphoid follicles, you have thyroid follicles, you have ovarian follicles, and you have hair follicles. Now what is it? Why do we call all these four things follicles? Just like that? If according to you a follicle is a ring, then why do I call a hair follicle a follicle and a thyroid follicle a follicle and an ovarian Graafian follicle a follicle? Come on, Deepak.
A follicle means the right, and the
Covering cells is
innermost
one
cells
type,
are-
okay.
inner-
Anything else that is common between these? No? Anybody else wants to answer? Rushali?
Anything that has some material inside and cells,
Material
epithelial cells,
inside.
like
Okay.
colloid or
Colloid, okay. What is this? What is the material inside the material you are saying? So what is the material inside a lymphoid follicle?
A cavity? Is
Is
that
there a cavity in a lymphoid follicle? You heard of a lymphoid follicle, Rushali?
yes, ma'am.
You've seen one?
Yes, ma'am.
Yes, ma'am. You think there's something inside it, Rushali? Huh?
No, ma'am.
No, ma'am. Okay. Mukta, you're the one who's done most histopathology, Mukta. Come on. How does one define a
follicles are-
follicle?
Cluster of different types of cells,
Oh my God.
which
So
has
then a thyroid follicle, Mukta, has got many different kinds of cells. A cluster of many different kinds of cells. Come on, Mukta. Jagrat,
Yes, ma'am. They are secreting something.
they're secreting something. Acha. What is being secreted by a lymphoid follicle, Jagrat? I don't think anything is being secreted, right? By a lymphoid follicle. What is being secreted by a hair follicle? Nothing. Swati,
a spherical structure.
who said that? Deepak?
Yes.
Yes, you have finally hit the nail on the head, Deepak. And for everybody over there, a follicle is described, I mean, we describe it in histopathology as it's a name for a spherical structure. And you know, Deepak, what is a sphere?
A sphere means a three-dimensional structure. Which
Yes,
is
I know
round.
it's three-dimensional, so is a box. Yes. So what is a sphere? It's a three-dimensional structure, very good. But what is it?
It is round.
Ah, yes. So it is a three-dimensional round structure, right? So a
Yeah.
ball or the planets or what else? Your lymphoid follicle. Nobody says that a sphere has to be solid, nor does anybody say that all spheres are. So every sphere is not solid. Some of them can be hollow, no? So it can be three-dimensional, it can be solid, or it can be hollow. So now what do you think that a lymphoid follicle is? Is it hollow or is it not?
It is not. It is solid.
It is not. Exactly. It is a solid sphere. What about the ovarian follicle?
solid.
Yeah, Daksha?
Yes, ma'am.
Yeah, what is an ovarian follicle? Is it hollow
So
or
round.
is it?
Rounded.
I know
Not
that it is rounded, Daksha. What is the definition? What did Deepak say is the definition of a follicle, Daksha?
It's a three-dimensional spherical structure.
So it is a sphere, right? Exactly. Now, is a Graafian follicle, is it hollow or is it solid?
Solid.
Oh, Daksha says that a Graafian follicle is solid.
Sorry.
Deepak,
Sorry. It's hollow.
it is what? Deepak, what is a Graafian follicle?
It is hollow, ma'am. Sometimes it is hollow.
Sometimes it is
Um,
always hollow. What does it contain?
Egg, ma'am.
What does it contain? a
Eggs,
Graafian
ma'am.
follicle? Huh?
Oh,
Hair.
Ovum.
What does it contain, Deepak?
Ovum.
It contains an ovum. Yes. Have you seen how big an ovarian follicle can be? And how big is an ovum? So the only thing that it contains is an ovum, Deepak.
Some antral fluids.
Ah, there is antral fluid. Excellent. And what does the antral fluid contain?
Who's second?
Oocyte, my God. Yes. Mukta, what does the antral fluid contain?
Nutrients for
Nutrients. Yes, Mukta? No? Mukesh?
Ma'am,
I
fluid
guess-
and knowledge.
What does it contain? You don't know that it contains estrogen, huh? Okay, that's what it contains, my friends, huh? The developing follicle contains estrogen, and it's high time that you people know about various things. All right, let us come back to the thyroid. But what I wanted you people to understand is that you think that a follicle is always hollow or it's a ring. It is not a two-dimensional structure like a ring. Okay, it's a three-dimensional structure. So even a thyroid follicle is a sphere. Okay, it's a rounded structure which is hollow. And in that hollow, what is there in that hollow? Huh? Mukesh, what's in the hollow?
In hollow, there is secretion.
Secretion. What secretion?
Colloid. What is
Colloid.
colloid?
Yeah. So what is that colloid? What is there
Colloid.
in that colloid?
Then colloid mainly is formed by the iodine.
Colloid is formed by iodine.
T3 and T4, ma'am, mainly.
Yeah, but what do we call that material which is there in that thyroid? In that colloid material. Yes, there is T3, there is T4, there is the thyroid hormones. You ever heard of something called thyroglobulin?
Yes, ma'am.
Ah, you did. Okay. So that's what's in that follicle, which the thyroglobulin which binds the T3 and T4. Okay, very good. So that is what a follicular patterned lesion is. Deepak, can you once again repeat what is a follicular patterned lesion?
it is a spherical three-dimensional.
A follicle is a spherical three-dimensional
Three-dimensional
structure.
structure,
When
which
we are
contains-
talking about the thyroid, what is a follicular patterned lesion?
In case of thyroid, follicular pattern means follicular epithelial cells are arranged in a ring-like fashion and containing colloid.
Exactly. So that is what a follicular pattern. It may or may not contain colloid. It may be a little colloid. It may be a lot of colloid. The
Little
follicle,
colloid.
the patterns may be large. They may be small.
Small.
But all of them have a ring-like appearance in a two-dimensional structure, which we see in our histology slides. Most of these follicular pattern lesions contain colloid. Very good.
Colloid.
So now let's go to the next person over there. Naina, what is an adenoma? Are you there, Naina? Naina, have you disappeared? Naina has disappeared. All right. So let's go to Diksha. Diksha, what is an adenoma? Because you said that you had heard of a follicular adenoma, right?
Benign tumors.
It's a benign tumor. Very good. An adenoma is a benign tumor in the thyroid. How would we know that something is an adenoma? Diksha, any idea? You've seen one, right? You told me you saw a Hurtle cell adenoma, right, Diksha?
Yes, ma'am.
Very good. So if you can think back, Diksha, what was that Hurtle cell adenoma like? How does one define an adenoma? You saw one. That's why I'm asking you.
It was derived from epithelial cells, epithelial tissues.
What epithelial tissues, Diksha? What epithelial tissues do you see in the thyroid? Is there any epithelium that you see in the thyroid? Okay, Diksha is Mukesh, tell me, what is the, she says that
Squamous.
an adenoma is a benign tumor of epithelial tissues of the thyroid. So what epithelium is there in the thyroid?
Ma'am,
Mukesh?
mainly the follicles are lined by the main cuboidal cells. Then after secretion, the main.
So what are those cuboidal cells?
Then the cuboidal cells are
What do we call those cuboidal cells? Mukesh?
follicular cells.
Follicular cells, yes. So that is that Diksha was talking about an epithelium. So do you think that those follicular cells form an epithelium or not? Mukesh?
Yes, ma'am.
They do. So that is a follicular epithelium of the thyroid. So now, Diksha, all those ring-like structures that you are seeing in the thyroid are lined by follicular epithelial cells. There is an epithelium in the thyroid which is forming follicles, and that's why we call it a follicular epithelium. Very good. Now, Swati, what is an adenoma? She told me that it's a benign tumor. How do you recognize it, Swati?
Proliferation of the normal cells which are within the tissue.
What? Normal? How can it be normal if it is a tumor? Is it a tumor or not a tumor?
Ma'am, it's a benign
Yeah, but it's a tumor, right? So how can it be normal?
benign proliferation of the cell.
All right, very good. There's a benign proliferation. That's very good. But how do you recognize it as an adenoma? Is there anything specific that you look for in the thyroid that tells you that this is an adenoma?
It is always well demarcated.
It's always well demarcated. Anybody wants to add to this well demarcated
And there'll be a presence
Totally
of
surrounded by a capsule.
Capsule. No capsule
That
invasion.
is excellent. Yeah, and Deeksha, you should have seen this when you studied your Hurtle cell adenoma, that all adenomas in the thyroid, by definition, are surrounded by a capsule. It is a capsule around that benign tumor, and that benign tumor is obviously spherical, and it has a capsule that is outside of that tumor, which is separate, of course, from the capsule of the thyroid gland. So whenever you want to call something an adenoma in the thyroid, you have to look for this capsule. All right, very good. So, Jagrat, how is a follicular tumor defined?
Follicular tumor can be defined through by its first appearance by histological architecture. No?
Yeah, so what is that histological architecture that defines a follicular tumor?
They can be large and heterogeneous.
Can be, no. It is. You please tell me
Yes.
is. It's not about can be.
Yes, ma'am. The size is very big and it's
The
heterogeneous
size has to be big. Okay, why big? Why can it not be small?
because of neoplasm changes.
Because it's a neoplasm, so it has to be big. There are no small neoplasms, Jagrat.
Yes, ma'am.
There are small neoplasms. So how do we define a follicular tumor? Any idea? Have you seen a follicular adenoma, follicular carcinoma? Have you seen?
Yes, ma'am. Follicular
Right. So how do you define it?
we can define through its encapsulated.
All right. So it can be encapsulated, but if it is an adenoma, it is encapsulated. If it is a carcinoma, is it encapsulated?
Maybe, may not be.
So it may not be. No? So what defines a tumor?
all the tumors arranged in a follicular pattern.
It's arranged. Aditya says it's arranged in a follicular pattern. All right. So according to you, Aditya, anything that is arranged in a follicular pattern is a follicular tumor. You agree, Aditya?
No, ma'am. Ma'am,
No,
all
madam. Then why did you say that?
ma'am, the tumors which are arising from the normal follicular cells of the thyroid are known as follicular tumors, ma'am.
Oh no, not at all. Then you answer the next question. What is a papillary carcinoma? Is it
It
where
is
is it
also
arising?
arising from follicular.
There you are. Vrushali says it's also arising from the follicular epithelium. So how do we define a follicular tumor? Yes, come on, Vrushali.
Ma'am, when there is proliferation of normal follicles,
Normal follicles.
not
What do you mean
normal,
by
but
proliferation of normal follicles? Again and again, we're talking about proliferation of normal follicles. Huh?
Follicular tumor means there is.
Tumor arranged in
1 minute, one by one.
predominantly follicular pattern.
Predominantly follicular pattern. Okay.
Ma'am,
So
there
then,
is.
come on, Mukta, what is a papillary tumor then? What is a papillary carcinoma? It has to be predominantly
Papillary
papillary. Is it?
carcinoma, more than 1%
No.
papillary pattern.
Oh my goodness.
Zero.
I see.
nuclear
All right,
changes are
and
also
then
seen.
now you know why I'm talking about a conundrum. Now you guys, this is a very common problem, no? A very common thing to get follicular tumors, to get papillary tumors. Everybody knows that you can get papillary carcinoma in the thyroid, you can get follicular adenomas, you can get follicular carcinomas, you can get Hurtle cell adenomas, Hurtle cell carcinomas in the thyroid. They're all derived from follicular epithelial cells, okay? But nobody's telling me the definition. All right, we'll have to come to the definition of this particular thing. All right, now the last question. Aditya, you're appearing for DM. Is there such a thing as a papillary adenoma?
No, ma'am.
Yes, ma'am.
Now somebody, wait a minute, now one by one. Let me, Aditya, what do you say? No, ma'am. Very good. Deepak.
Follicular
I
adenoma
asked
with
you a
papillary
question.
architecture.
1 minute. Deepak, please don't try and evade the question. There is the last question here. Is there such a thing as a papillary adenoma? It's a yes or a no, Deepak.
No, ma'am.
No, ma'am. All right. Daksha?
No, ma'am.
No, ma'am. Vrushali? She
Yes,
said
ma'am.
yes, right?
Yes, ma'am.
You said, Vrushali said yes. Mukta?
Yes. Ma'am, papillary
The question is-
architecture can be there in adenoma.
I want a yes or no answer, Mukta. Is there such a thing as a papillary adenoma? Vrushali says yes. All three before her said no. Now you please hurry up and make up your mind. Then we have Jagrat. Come on, Jagrat.
Yes, ma'am.
No.
There is such a thing. All right. So you are with Vrushali. Very good. Swati?
Ma'am, there's nothing like papillary.
There is nothing like papillary adenoma. So you're with Aditya, Deepak and Daksha. Very good. Mukesh?
No, ma'am, there is no papillary adenoma. There is papillary variant of follicular.
All right. So you have got, Mukesh says no. Excellent. That means he's with those of them who said no. Mukta, have you thought very hard? What do you want to say?
Yes, ma'am.
So there
No,
is.
ma'am. It's not papillary adenoma.
There is no
Follicular
papillary.
adenoma.
So we have Vrushali and we have Swati who say that there are. Okay, Deeksha? No, Deeksha won't know. Naina? Naina's gone. Naina's not there anymore. Ruchi, is Naina there or is she gone? I think Ruchi's also gone. Okay.
No,
Fair
ma'am.
enough. So now let us see when we come to our talk what the answers to some of these questions. All right. So now I'm going back to the classification of thyroid carcinoma, which was in WHO 2004. It's a long time ago, and you might wonder, why should I know about what happened 20 years ago? We are now in 2024, and you want to know why should I think bother about it? Well, it's very important to bother about it for the simple reason that those who forget history are doomed to repeat it. All right. So now let us see. This is, for all practical purposes, normal thyroid. Yes. Okay. And what is the normal thyroid made up of? Somebody was telling me that there's follicular epithelium. Is there anything else in the thyroid?
Different size of follicles.
Different size of follicles. Never mind. But you have
C cells.
follicular,
Parafollicular.
follicular, or C cells. Okay. You know how to use your annotation. Deepak, you know how to use annotation?
Yes, ma'am.
All right. Ask for annotation and please show me what is follicular epithelium and what is. Oh, okay. Here, I've approved. Now come on. Show me what is the follicular epithelium and what are C cells.
These are follicular epithelial cells.
Follicular epithelial cells. All right. I can see he's made a red mark, but he's made it extremely thin. Let me. This is what you showed, right?
Yes, ma'am.
Yes. So all these. Now, can you describe those follicular epithelial cells?
Follicular epithelial cells, ma'am. These one.
Describe them. You know what is the meaning of description, right?
Follicular epithelial cells are ovoidal to columnar, depends on its activity, and have a round to oval nucleus with a
Do you see any oval? Do you see a single oval nucleus?
round
Then
nucleus.
why did you say oval, Deepak? You
I'm
guys
sorry.
have a way of hedging your bets. I'll say
Round.
grey white. I will say round to oval when I mean round. In case there is one oval cell, Deepak, if you can show me one oval cell, I will give you anything that you want. Is there a single oval cell? The answer is no. They are all perfectly round. Yes. Okay. So they're round cells. Okay. Then that means the nuclei are round. Yes, they can be cuboidal, they can be short columnar, and maybe, like you said, if there is a lot of activity, it may actually be a little more columnar. Excellent. So that is the description, right? What is the nature of these nuclei? They are not just round. Anything else you want to say about them? That's it. They're round. Okay, they're bland. Very good. Anything else?
Only distributed chromatin is present.
So it is well distributed. Actually, you can hardly see. They're not vesicular. No, they are usually quite dense. They're not as dense as lymphocytes, but they can be as dense as lymphocytes and lymphocyte nuclei. So that's what it is. It's perfectly round. Now, anybody can see a C cell over there? Somebody just asked for annotation. Okay, Aditya, can you ask for annotation?
Yes,
Show
ma'am.
me a C cell.
Yes,
Can
ma'am.
you see a C cell?
Yes,
What's the
ma'am.
answer, Aditya?
Ma'am, at the top bottom, I'm not able to mark it. Just a minute.
No, why can't you mark? I've given you who? I don't know. I approved some annotation. Who's this? Jagrath. All right, come on, Jagrath. Whoever. Those are C cells. Why do you think they're C cells, Jagrath? They look like thyroid follicular cells, and they've actually got a little bit of.
One, two,
thyroid
six,
mixture.
yes, ma'am. One, two,
Whose orange thing is that?
Me.
Rushali.
Yes.
So Rushali has marked something that are very likely to be C cells. You see them? They have little larger nuclei. They may even have a nucleolus. Okay. So that is what is a parafollicular C cell. Okay, Deepak has marked the same thing. Okay. So those are C cells in the thyroid. Very difficult to see. You do not see normal C cells in the thyroid. Okay. It's very difficult to see, but yes, somebody did mark the C cells over there, and these are C cells where the arrow is. That's the only real C cells that I could see in this particular in this picture. They're very difficult to see. Quite often you mark. Now somebody might have marked. Let me just change my. Who is talking? All right, now here is my laser pointer, and if you look at this, someone might think that these are C cells. They're not. And this is exactly why it is important for you guys to understand that thyroid follicles are spherical. And when something is spherical, and if you cut the top of a sphere, yes, what will it look like? What does it? If you cut through the top of a sphere, Swati, what will it look like? What will it look like?
Linear.
It'll look like what? It'll look like a sheet. Look at this. Where you see my cursor going. Okay, that is the top that has been chopped off from a sphere. So when you have a sphere and you pass your knife over the top of a sphere, that's what it will look like. And many students mistake these for C cells, or like somebody mistook this for C cells. Okay, that's nothing but the edge of the top of the sphere. So that is what C cells are not. C cells I've shown over here as a where the arrow is. Okay, and if you really want to show C cells, then you have to use a special technique. Okay, so now let me ask Daksha. Daksha,
Yes,
here
ma'am.
are the C cells. They are marked. Okay, what technique
Yes,
is
ma'am.
marking it, and what is the marker?
I don't know, ma'am.
Okay, Daksha doesn't know. Somebody wants to help her?
Calcitonin.
IHC calciton.
Well, it can be calcitonin. What else could it be? What is the technique? Somebody said it. What is the technique?
IHC.
Immunohistochemistry. Yes. And what is the marker? What markers could it be?
Calcitonin or synaptophysin.
Yes. So it could be any of the markers that you use for neuroendocrine cells, and the two most common markers are synaptophysin and chromogranin. Okay. So they will mark any neuroendocrine cells. And this, if you're wanting to mark the C cells specifically, then you have to use calcitonin. Okay. So now can anybody, Mukta, will you tell me, is this calcitonin, synaptophysin, or chromogranin? Mukta, are you there? Mukta also disappeared. Okay, so Mukta is gone, Naina is gone. All right. Who's this? Who was wanting to say something? Say no, whoever was wanting to say. Who's this? Yes, she's Mukta. You'll come back. Mukta, can you tell me? Yes, you are audible. Can you tell me, this is immunohistochemistry, and this immunohistochemistry is marking the parafollicular C cells. Now, can you tell me which of these three markers is this? Calcitonin, synaptophysin, or chromogranin?
Calcitonin.
Calcitonin. Achha, very good. Why is it calcitonin, Mukta? Why is it calcitonin? Why isn't it synaptophysin? Why isn't it chromogranin?
Nuclear
Alright.
markers, sir.
It is a nuclear marker. You think this is a nuclear marker? And according to you, calcitonin is a nuclear marker. Yes? Huh, Mukta?
No, ma'am. Synapto and chromo are the nuclear markers. This is.
Oh my goodness, Mukta, don't tell people that you come from TMHR if you say that synaptophysin and chromogranin are nuclear markers. Huh? What, Mukta? So what is synaptophysin, chromogranin and calcitonin? Are they nuclear markers or what are they, Mukta?
And synapto and chromo are some cytoplasmic markers.
And calcitonin is what kind of marker? Huh? Swati? Swati, are you there? Swati is also buzzed off. Okay, let's ask Mukesh. Mukesh? Synaptophysin and chromogranin, according to Mukta, are cytoplasmic markers, and she is not telling me what calcitonin is. So Mukesh, can you tell me whether it is calcitonin is a nuclear or a cytoplasmic marker? Yes, Mukesh? Cytoplasmic. And why are you being so hesitant? And these are all, what is synaptophysin, what is chromogranin, and what is calcitonin? What is calcitonin? Come on. Come on, Mukesh, what is calcitonin? It's an osteoclast inhibitor. I'm asking you about the physiology.
It's a hormone produced by C cells.
It is a hormone produced by
Hormone
C
produced
cells.
by-
It is a peptide hormone produced by C cells. So is it going to be in the nucleus? Hormones are in the nucleus?
No.
No.
No, ma'am.
Yeah, but common sense is never common, right? So calcitonin has to be in the nucleus. What is synaptophysin and chromogranin? Does anybody know? Synaptophysin is a protein that is present in the what we call the microvesicles, right, of a neuroendocrine cell. So it cannot be in the nucleus. And chromogranin is nothing but a protein that is expressed on the membrane of the vesicle in which you have the peptide hormone. So it has to be in the cytoplasm. These are all cytoplasmic stains. And I know that you guys think you know a lot of things, and it is not part of my talk, but I thought that I should find out how much you know about what is happening in the normal thyroid. Okay, but today we're not doing anything of that sort. What are we doing? We're just looking at a very small part of the wide number of thyroid carcinomas. Okay, and we're only looking at tumors of follicular epithelium that are well differentiated, and these are follicular and papillary. And I was asking you about how do you recognize and define follicular and papillary lesions, and we will do it now. And we are looking truly only at follicular and papillary lesions. We are not looking at true papillae. We are looking at the follicular patterned lesions that constitute this well differentiated tumors of follicular thyroid, follicular epithelium. All right, good. Now here are the definitions, and the definitions have remained more or less the same until what happened in 2022, and we will talk about that as we go along. Okay, in thyroid tumors that were defined, and it remained the same all the way up to 2017, is that we first defined a papillary carcinoma. No follicular lesion can be defined on its own. So follicular lesions were definitions by exclusion. So you defined a papillary carcinoma, and you must remember this definition because it still exists. Okay, it is a malignant epithelial tumor showing evidence of follicular epithelial cell differentiation. And what does that mean? That if you do immunohistochemistry, it will show you a derivation from follicular epithelium. It will be PAX8 positive. It will show you thyroglobulin if you want to stain it for thyroglobulin. Okay, it will also express TTF1. All right. So a malignant epithelial tumor showing evidence of follicular epithelial cell differentiation, typically with papillary as well as follicular structures. And we have defined what a follicular pattern is, and that follicular pattern is, as Deepak had said, that it has got a ring of nuclei, cuboidal or low columnar or sometimes columnar. And in the center, there may be little or a lot of colloid. Okay, but what really defines this papillary carcinoma, and we still believe it today, except for some exceptions, which we will talk about, as typical nuclear features. You cannot do without these typical nuclear features, all right, if you want to define a papillary carcinoma. And those typical nuclear features are ground glass, large, pale, and vesicular nuclei with grooves and pseudo inclusions. Okay, these are not true inclusions, but they look like cytoplasmic inclusions inside the nucleus. And the important thing is, and please, those of you who said that there are papillary adenomas, there are no papillary adenomas. Okay, follicular tumors do produce some papillary structures, but they are not called papillary adenomas. They're called follicular adenomas with a papillary morphology. And there was a very nice paper. If any of you read these sort of papers, as far as I know, most students don't read papers; they only read textbooks. And this is what was written by Juan Rosai. And Juan Rosai he passed away 2 years ago, but he was a doyen of surgical pathology. And he said, at present, a thyroid tumor can have papillae, follicles, solid, trabecular, or cribriform pattern of growth. It can be composed of large, small, oncocytic, clear, round, spindle, or columnar cells. It can be encapsulated, minimally invasive, or widely invasive. In some, it can have any of these features and more, as long as it has what are called PTC-type nuclei. All right, Deepak, what are these PTC-like nuclei?
Papillary thyroid carcinoma type
Yeah, that's what PTC stands for. But what are those PTC-like nuclei?
orphan eye nucleus. It is
Orphan eye nucleus, okay?
means ground glass nucleus with nuclear grouping and intranuclear cytoplasmic inclusion.
Yes, so it's written over here, right? In this last paragraph of the first bullet point, that these are typical nuclear features: ground glass, large, pale, vesicular, with grooves and pseudo inclusions. These are the nuclei that are often referred to. They are vacant-looking nuclei, which are like the eyes of the cartoon character Orphan Annie, and that's why they were called Orphan Annie nuclei. So this was what it was. It didn't matter what kind of pattern of growth it was. It didn't even have to have papillae, but if it had these nuclei, this tumor was called a papillary thyroid carcinoma, and there were no papillary adenomas. There still are no papillary adenomas. And on the right-hand side, I showed you in the first top picture, these three pictures. These are the Orphan Annie nuclei. You can see them in the top right-hand corner. They're seen everywhere, but this is with a typical papillary architecture. But you see the same nuclei in the bottom picture looks exactly the same, but there is not a single papilla to be seen. These are all follicles. This, yes, is referred to as the follicular variant of papillary thyroid carcinoma. All right, for years, this is what this was being referred to. It still is for a particular variant of papillary thyroid carcinoma, but there are some exceptions to this rule. All right, so now we come and I ask the question as how do you define a follicular neoplasm? A follicular neoplasm is not defined of itself. Okay, it is a well-differentiated neoplasm of thyroid follicular epithelium that is not a papillary carcinoma. It is a diagnosis by exclusion. Right? It doesn't have papillary. I mean, there may be some when it is a say it is a hypoplastic nodule, or you have a follicular tumor which is encapsulated. That means a hot adenoma. It is an adenoma that is secreting a lot of T3 or T4. Then it might have actually a columnar morphology. Yeah, and it might have pseudopapillary, but it does not have the characteristic features, nuclear features of papillary thyroid carcinoma. Has anybody got any questions? Ranu, is there anything in the chat box? If anybody has any questions before I go on to the next, any of you students have a question? All right. If there's nothing, Ranu, I'll go to the next. Anything in the chat box, Ranu?
No, ma'am.
All right. Okay. So follicular neoplasms are either adenomas or carcinomas. All right. An adenoma would have a nice capsule, and you can see the capsule over here in this picture. All right. So Deepak or whoever had answered was right that you have all adenomas in the thyroid must have a capsule. All right. Now, a carcinoma, on the other hand, has all the features of an adenoma, but demonstrates invasion of the capsule. That is what we call a minimally invasive follicular carcinoma. And necrosis is absent. When you have a widely invasive follicular carcinoma, again, it's composed of follicles. There are usually no papillae, and certainly there is no papillary carcinoma nuclei that are seen in these tumors. Okay. Now, what do we mean by invasion of the capsule? Here you can see the capsule, and there is a mushroom that has mushroomed out through that capsule. You see that there is a capsule on two sides over here, and this tumor has mushroomed out of the capsule. Here you see actually vascular invasion. You see a small little tumor that has burrowed its way into the capsule, and through that capsule into a capsular vessel. Okay. So the vessel has to be not within the tumor, but in the capsule or outside of the capsule. I hope everybody has got this definition. Okay. So now we come to this issue of what is an encapsulated follicular patterned neoplasm. And it should be, I mean, it's so easy, right? If you have something that is encapsulated and follicular patterned, all you need to do, or we thought that we needed to do, was what? Look for the nuclear features of papillary thyroid carcinoma. If we found the nuclear features of papillary thyroid carcinoma in an encapsulated follicular patterned lesion, Aditya, what would we call it?
Ma'am, nuclear features of papillary thyroid carcinoma
are present. You have a follicular patterned lesion, and we know what is a follicular patterned lesion. What is it, Aditya? What is a follicular patterned lesion?
Ma'am, non-invasive follicular thyroid carcinoma with papillary-like nuclear features.
Non-invasive follicular tumor with papillary thyroid nuclei. Yes, but that is what you would call it today. All right. Once upon a time, that's not what we called it. We called it because it was believed that anything that had the nuclear features of papillary thyroid carcinoma was a papillary thyroid carcinoma. We used to call it an encapsulated follicular variant of papillary thyroid carcinoma, and this was so all the way up to 2016. Okay, so don't think it was only in 2004. All of the different descriptions, etc., of these tumors, the updates on thyroid pathology, etc., called this lesion an encapsulated follicular variant of papillary thyroid carcinoma. Right? If the nuclear features of papillary thyroid carcinoma were absent, and if it was non-invasive, it was called a follicular thyroid adenoma. If it was invasive, it was called a follicular thyroid carcinoma. And I don't think that there was anything more easy than this. Right? But then, when something is very easy, there is usually some little problem, or more than one problem, that crops up. And there was trouble in paradise. Okay, what is paradise? Anybody can tell me what is paradise? Rushali, what is paradise? What is paradise?
Heaven.
Heaven, yes. So in heaven, everything is easy, no? Yeah,
Yes.
Rushali.
Yes.
But we don't live in heaven, no, we live on earth. And so there was trouble in the real world. And what were the troubles? Number one, the first thing was, what constitutes encapsulation? How much of this nodule should have a capsule? And how do you tell a dysfunctional nodule, also known as an adenomatous nodule, that means something that is not an adenoma, from a thyroid, that means a follicular adenoma? That was the first problem. The second problem was this. What are the criteria for invasion in an encapsulated tumor? So how much of the tumor should, how much of the capsule should be infiltrated? A little, a lot, full thickness? Okay. What actually constitutes this? Because that made the difference between a follicular adenoma versus a minimally invasive follicular thyroid carcinoma. And the last thing was about PTC nuclei. Okay. Now I've got a follicular pattern lesion. It is nicely encapsulated, and I can see some PTC nuclei, but they are very few and far between. Or only 20% of the tumor has got the PTC nuclei. Okay. All these PTC nuclei have got some features. Maybe they're clear, but they are not grooved, or they don't have. They're not large. They're not overlapping. So, is this a follicular adenoma or a follicular thyroid carcinoma if it is invading its capsule? How do you tell that from an encapsulated follicular variant of papillary thyroid carcinoma? So these were the big problems, and they caused, and they still cause, a lot of what is called pathological thyrophobia. Now many people do not want. Somebody's microphone is on. Can you? I think just mute not the students, but everybody else, please mute yourself because we're getting an echo. All right. So these are the causes of pathological thyrophobia. And the reasons that we have thyrophobia, has anybody joined from different devices? Who has? Then please shut one device because then we get this echo. Who had joined? Deepak? All right. So, no, the echo is still there. So anyway, somebody has shut their thing now and the echo is gone. There were controversies in the management of differentiated thyroid carcinoma. And the question was, should a lobectomy be done versus total thyroidectomy? And should all carcinoma diagnoses warrant a total thyroidectomy, the whole gland to be removed? And there were many surgeons who still today will do a total thyroidectomy for a carcinoma diagnosis. I hope they're getting fewer and fewer and fewer, but there are many old-fashioned surgeons who don't use what is called risk-adapted therapy. Okay, so I think that this also reflects on how pathologists will make diagnoses. All right, they don't want to be caught on the wrong foot. Okay, so now let's take the first thing: dysfunctional nodule, or what some people call an adenomatous nodule, versus a follicular adenoma. Now here is a picture, and you can see this top large nodule is extremely well encapsulated all the way around. Okay, but you have two unencapsulated nodules over there. So what are we going to say? That these are dysfunctional nodules, and this is a follicular adenoma? Is it possible that you can get a follicular adenoma in a multinodular goiter? And the answer to this question, yes, we do see them, but how many, and whether they should all be called follicular adenomas, all right? So a follicular adenoma, by some definitions, is that it should be solitary, it must have a complete capsule, which this has. There should be compressed thyroid tissue beyond the capsule. This is too low power a picture for you to see that. And the morphology within and outside of the capsule should be different. It is. It's also different here in the dysfunctional nodules, okay? It's certainly different from within and without. So is this, we don't call this lesion a follicular adenoma. Why? Because it doesn't have a capsule. And the answer is probably yes, that this is a follicular adenoma and these are dysfunctional nodules. But does it really matter? That is the real problem. Okay. So this is the problem. Is an encapsulated nodule in a multinodular goiter a follicular adenoma? I don't know the answer to that question. All right. Why? Because 70% of dysfunctional nodules are clonal. And somebody want to tell me what is the meaning of clonal? Anybody wants to take that question? Swati, what is the meaning of clonal? What is the meaning of clonal, Swati? Deepak, what is the meaning of clonal?
Clonality means originate from a single type of cell.
Yes. So in other words, how will you know that something is clonal? Deepak, you know that you are clonal and I am clonal. Did we not arise from one fertilized zygote? Yes or no? Yeah. So what is clonal? Somebody called Priyanka has said a single species. That's not a good enough diagnosis. Yeah. Somebody called Tanya has said origination from proliferation of a genetic clone of cells. No, that doesn't help. Yes, Deepak, what is clonal? It means that if I test the cells, multiple cells from that one particular, each one of them would have the same genetic abnormality. Okay. I am a clone, Deepak, and you are a clone. Why? Because my genome, whether it's in my eye or in my skin or in my ovary or in the liver, this exact same genome is present in every one of my cells. So I am genomically, all my cells have the same genome. And that is true of the multinodular goiter, where there is an abnormality which is the same in 70% of dysfunctional nodules. And that same genetic abnormality, in other words, it's a mutation, or even sometimes it can be a gene rearrangement, is the same gene rearrangement or the same mutation that is seen in a follicular adenoma or a minimally invasive follicular carcinoma, which are these two are, of course, related to one another. So in other words, capsule or no capsule, 70% of dysfunctional nodules have been shown to have RAS mutations. So now, are we justified, therefore, in calling only encapsulated lesion adenomas? I think it's a philosophical question which we have to deal with. Okay. And what is the status of more than one encapsulated follicular lesion? It was said, and many textbooks still carry it, that to be called a follicular adenoma, you must have just one encapsulated lesion. And what do you do if you have multiple encapsulated lesions? The textbooks don't tell you. All right, but this has been tackled in the 2022 WHO classification, because what difference does it make whether you call these things multiple dysfunctional nodules or multiple adenomas? The bottom line is it makes no difference in practice, as both are absolutely benign. Now, to take care of this problem, in the new WHO 2022, it's now no longer new, it's 2 years old, there is a disease, or at least a definition for an entity. They have now named an entity. You can use this, or you need not use it. This is thyroid follicular nodular disease. Okay, so this was a name or a label that achieved consensus as the best way to describe what they call an enigmatic entity. Okay, enigmatic means something that is difficult to understand. I don't know what is difficult to understand about it, but they call it an enigmatic entity. And as far as I'm concerned, I don't care what you call it. Call it adenomatous goiter, multinodular goiter with follicular adenoma, whatever it is. But if the WHO now has come up with a term and your surgeons understand it, it's very important that the surgeons understand it. If you're working in a hospital like Tata Hospital, yes, they will understand it. But if you're working in places where surgeons have been used to hearing the term multinodular goiter, they will not understand what is thyroid follicular nodular disease. And therefore, if you want to use the term, please use it as a synonym. So in other words, thyroid follicular nodular disease, synonym multinodular goiter. Right? I hope I made that very clear. Okay. And this was what my old boss used to tell me: call it anything you want, doctor, but don't call it a cancer. All right. So that's about dysfunctional nodules. Now, what about this question about invasion of the capsule of lesion? So follicular thyroid adenoma versus minimally invasive follicular thyroid carcinoma. Okay. And this is the definition that you see even today in all of the textbooks. All right, a minimally invasive follicular thyroid carcinoma is an encapsulated follicular neoplasm which demonstrates invasive characteristics. Now, what are those invasive characteristics? All right, come on, Jagrat, what are those invasive characteristics?
There will be capsular invasion and vascular invasion also. You can see.
Yeah, so capsular and vascular invasion. Capsular and vascular invasion can be very subjective things, right? So somebody had to define what is capsular invasion. So what is the definition that is written here?
Full thickness. Full thickness.
In capsule, which is usually thick.
Exactly, full thickness invasion of the capsule, which is usually thick. It's very, very, very unlikely that you will get a minimally invasive follicular thyroid carcinoma with a thin capsule. Okay, so the capsule is usually thick. And when it is defined as vascular invasion is defined as tumor emboli, which must be seen within or outside the fibrous capsule and be covered by endothelium. In other words, it's stuck to the endothelium, and the endothelium, because it is an embolus, or like you understand thrombi within vessels, the endothelium then grows over the embolus or the thrombus, as the case may be. So this is the definition. Okay, but as I said, we do not live in paradise. Okay, we live in the real world, and the tumors, my friends, do not read the textbooks that we write. Why should they read the textbooks that we write? We write our textbooks, and the tumors will do exactly as they please. Very good. So now, if you want to be absolutely idealistic. Here it is. This is invasion of the capsule, which is a genuine mushroom-like invasion of the capsule. And here is the invasion of a vessel within the thick capsule wall. Now, please notice that the capsule is thick. It is very unusual, as I said, to get minimally invasive follicular encapsulated thyroid carcinoma when the adenoma is very thinly encapsulated. This is an absolutely iconic diagram. It is comes from this this article that was written by Ronald Gossain, who was the head of head and neck pathology at Memorial Hospital. And you can go and look it up. But this is the diagram that everybody knows. Now, he drew this nodule, which is the orange-colored or red-colored neoplasm. And there is this green thick capsule. And he has shown, as for instance, H is down here. And this is classical capsular invasion. And that's why he has said yes. So H is yes for capsular invasion. Who is talking? Okay. Please try not to talk, because then we get an echo. Then he's shown G. And these are small foci of tumor within this thick capsule. Now, it's very difficult to know whether that is true capsular invasion or no capsular invasion. And according to Ronald Gossain, this should not be called capsular invasion, because these tumor nodules are run parallel to the outline of both the capsule and the nodule. Now here, he's got F. I'm just going through this one by one, because here the difference between G and F is perpendicular. So it looks almost as if it's making its way directly outside the capsule. But according to Gossain, it is not yet to be considered as capsular invasion. Let's go to E. It is well outside of the capsule, and therefore, yes, there is no connection with the thyroid neoplasm, but it's outside and it looks exactly the same, and it should be considered as capsular invasion. I'll skip D for the moment. Let's go to C. C is yes. It doesn't look like a mushroom. It's more like a bullet. And yes, the mushroom one was H, which is diametrically opposite C. Okay. Now what about B? Okay. B is very interesting. It's like a little hillock. You can see that. It is a substantial amount of thyroid neoplasm, like a hill, but it still has the capsule on the outside. And so according to Ronald Gossain, it is not yet. But you notice that I have put some dotted arrows. I've done it for D, I've done it for B, and I've done it for I. And we'll discuss why I have pointed out specifically to these areas, right? This small little bump as A is not considered capsular invasion. It is just an irregularity in the growth of this neoplasm. It's not perfectly arc-like. And J, it's also said to be known. There's a small spike and a small little area over there, which he doesn't consider as yet. Now, I looks every bit like H, except that it hasn't gone full thickness, okay? And you can see that B looks every bit like C, but it hasn't gone full thickness. Now, let us come to D, okay? Now, this D is, why has he said yes, when you can see the capsule very clearly beyond it? Why he said yes is because slow-growing tumors can build a capsule after they have already penetrated the previous capsule. Okay, so I saw that Anshu had written over here that many of these can be sinus tract when somebody has done an FNAC. Yes, it's possible. You have to look to see whether there is blood in that tract or whatever. But according to Gossain, that's why only according to Gossain it makes sense that you can have multiple capsules that occur after the first capsule has been breached. And this is what he's saying. And that's why he's drawn a dotted line that this was the original capsule. This tumor has gone through it, but another capsule has formed. So although there is a capsule beyond the tumor, that is a secondary capsule, and it should be considered as invasion of the capsule. I won't go too much into vascular invasion because I already told you what an embolus is. Now, can you imagine the confusion that occurs when somebody thinks, particularly when the tumor is not all so nice and round, and its capsule is so beautifully placed, and it is a large tumor, and you have to take many sections of this tumor. You may not be able to actually see everything as beautifully as is seen in a diagram. Okay, so it becomes very, very difficult. Okay, now let me ask you a question here. Do you think that this is invasion of the capsule? Yes or no?
No.
Who's saying no? I see lots of no's. Who said no? Aditya said yes or no?
No, ma'am.
No, ma'am. Deepak?
No, ma'am.
No. Daksha?
No, ma'am.
No. Okay. Rushali?
No, ma'am.
No. Mukta?
No, ma'am. It's not.
No. Jagrat?
No.
Swati? Swati, are you there?
Yes, ma'am.
No. Mukesh?
No, ma'am.
All right. And Diksha?
No, ma'am.
Diksha, I know that you've not seen many, but just take a guess anyway. But make it an educated guess, because I just told you about how.
No invasion.
Yeah. So what, Diksha?
No invasion, ma'am.
No invasion. I don't know if Naina has come back.
Hi, son.
Oh, you have? Okay. Very good, Naina. So what do you think? Is this invasion or no invasion?
It has mushroom shape, but also it's
It has mushroom shape. But what's the but?
still I don't think it's an invasion.
You don't think it's an invasion. Where do you think, Naina, this particular tumor is? Where do you think it is? When I say where do you think, in relationship to the thyroid, yes?
Within the capsule.
What is this outside? Do you think it's the capsule of the thyroid, or is it the capsule of the tumor?
Capsule.
Capsule of thyroid.
Tumor.
Wonderful. It's the capsule of the thyroid, and everybody is telling me if this is the capsule of the tumor,
Yes.
to which it has mushroomed, and you're telling me that this is not an invasive tumor. Of course, it is invasive. There is no thyroid beyond that, is there? No, this is the capsule of the thyroid. So, am I asking you whether this has gone through the capsule of the thyroid, or am I asking you has this gone through the capsule of the lesion, of the capsule of this tumor? What is the question I'm asking you, Deepak?
It is going outside from the tumor capsule.
So it has breached. You can see here a narrow neck and a mushroom shape. Okay, so it has gone through its capsule. So yes, in my book, this is a invasion of the capsule. You have to look carefully as to what it is that we are actually seeing. This is not the capsule of the tumor. This is too thick to be the capsule of the tumor. You can see the capsule of the tumor, which is here, and you can see the thickness of this capsule of the tumor, and this tumor has mushroomed out through the capsule of the tumor. So in my book, yes, it is an invasion of the capsule. What about this picture down here? Aditya?
Ma'am, no invasion, ma'am. Sorry.
No invasion. Very good. Deepak?
No invasion.
No invasion. Daksha?
No invasion, ma'am.
Does anybody think it's invasion? Huh? Nobody? Yes?
No.
Somebody? Does anybody think it's invasion? No. Well, is there anybody in the chat box who thinks it's invasion?
No answers, ma'am.
No answers. Well, it most certainly is invasion.
If,
This is
one of
another-
the-
this is
yes,
a- this is another capsule that is formed outside. You can see this is the capsule. It has broken through, and a capsule has been. So this is the capsule of the lesion, and you see it as a tongue or a tuberculum that is over there, and outside that another capsule is formed. So this is invasive. Apart from anything else, look at this tumor. This tumor is so solid. It is not like this tumor, which is so. But this is invasion of the capsule. Then what am I telling you? This is a difficult area. Some people will say yes. Those who are novices will say no because they've been told that they have to see full thickness invasion of the capsule. Yeah, and they see a capsule here and they say it is not invaded. Yeah, but there is a capsule here, and that capsule has run through that capsule, and now this is like Ronald Hussein's. Yes, for D. It is like D because a capsule has formed after this. So you draw a line. That was its original capsule, okay? And you draw a line like this, and this is way outside that capsule. So I'm just telling you that these are the problems that you will encounter. All right. Now here is an expert. Okay, this expert is Saul Schuster. He writes on Moran and Schuster write a lot on thyroid disease. Okay. Now he has this picture in his book, in his chapter here, Archives of Pathology and Lab Medicine. And you see this. It's like a hook that has penetrated into the capsule. Yeah, but there is still some capsule on the other side, and many people might think, oh, it hasn't gone the full thickness. And so what does Schuster say? Partial but incomplete penetration of the capsule by tumor has been widely regarded by some, and I count myself in that category, as being sufficient to qualify for invasion and therefore for a diagnosis of carcinoma. However, a consensus regarding the significance of such a finding is not yet available. Okay. Now, how will you ever find the consensus for such a finding? The only way that you will ever find a consensus for such a finding is that if you have a number of these lesions which are questionable capsular invasion and you follow them for 40 years and then you discover which of them has metastasized. I don't think that that's very easy. But suppose you do it the other way. You find tumors that are metastasized and then look at what their original tumors were. And if you find some like these, then you have to accept that this was there. And somebody actually published a case that said exactly that. Okay, sorry. And here is another one. Is this vascular invasion? Okay. And there is definitely capsular invasion, but is this vascular invasion? And I think yes. Why? Because there is thrombosis. You can see that there is a thrombus that is formed. It's a fibrin thrombus, and fibrin thrombi do not form unless there is breach of the endothelium. So if somebody is not convinced that this is vascular invasion, then I think common sense, even though you don't see an endothelial lining to it, there is fibrin there, and I would consider this as vascular invasion. Okay. Now here is Schuster again. Okay, and on this side is, I would say that she's the doyenne of thyroid. Surgical pathology of the thyroid, and that is Virginia Livorsi. Okay, and I'm just showing you two different experts. The students don't have to get confused, but this is for those who are listening who have been practicing for a long time. Now see what Schuster says here in more or less the same years. Okay, 2006 and 2007. So what does Schuster say? Figure 1, that's number 1. Okay, minimal irregularities of the capsule should not be considered as evidence of capsular invasion. Okay, so he doesn't think that is invasive. Now here again, focal attenuation and disappearance of the capsule in follicular neoplasms can be confused with evidence of capsular invasion, but he doesn't think that this is capsular. These two things are not capsular invasion according to Schuster. Okay, which he was saying the same thing in the previous. He thought it was not, but some people he said think so. Now look at this picture on the right hand side and the caption. Okay, do you see? It is much less than what has been shown by Schuster in figure number 1. And yet, see what Livorsi and Baloch call it. Capsular invasion in follicular carcinoma showing tumor cells invading into but not through the capsule in a hook-like manner. And then they say in brackets, some pathologists consider this atypical adenoma or tumor of undetermined malignant potential, uncertain malignant potential. Now you see the difference? These are both experts. All right. And one thinks that what's on the right should not be considered, and the other thinks that it should be considered and would definitely consider what is figure 1 of Schuster, invasion of the capsule. Now I know that everybody's thinking, oh, we are not experts and what should we do? Well, there is an answer to everything. Okay. Right. So now here is somebody who published this, and I'm so glad that they published it. Okay. So the question was, how can we be sure that all cases with incomplete invasion are truly benign? And now here is a consultation case. This was a 61 years on mine. It's somebody who published it. 61-year-old female who developed distant metastasis. She was found to have metastatic thyroid carcinoma in the sacrum. And then they reviewed the histological slides of the primary thyroid nodule treated at a local hospital 14 years before the metastatic carcinoma, years after. Okay, and it revealed only what Schuster would say: questionable capsular invasion. Okay, and questionable vascular invasion. If this was a vessel, was there invasion into the vessel or not? But this lesion had metastasized. So the question is, which of these not yet are actually yes? It's a difficult problem, and I don't think that difficult problem is going to be solved anytime soon as with respect to the diagnosis. Okay, but we have to find an answer, right? So is there a difference between the invasive and the non-invasive tumors? And the answer is no. There is the same chromosomal loss at 3p25, RAS gene mutations, PAX8, PPR gamma rearrangements. But there is something different about the gene expression profile of those tumors that show angioinvasion. And angioinvasion, I think, is much easier to diagnose than capsular invasion, and therefore angioinvasive carcinoma can be a different disease. So now, what should be our criteria? Well, as far as possible, we should try and look for full thickness invasion of the capsule, endothelial line tumor within a vessel, and your diagnosis should be qualified by angioinvasive or capsular invasive. And for a long time, people thought if there was, after this paper, that if there are more than 4 foci of angioinvasion, that is a really bad disease. But I think it doesn't matter whether it's 4 or it is 1, as long as it is angioinvasive, that is definite invasion. And I think that those patients are at high risk for the development of metastasis. Okay, so this is really the bottom line. Follicular tumors with extensive transcapsular invasion or unquestionable vascular invasion show a definite risk for metastasis. Okay. Any other extensive transcapsular invasion, it doesn't mean just one little nodule. Of course, call it a minimally invasive follicular carcinoma, but make certain that you say that it is 1 or 2 foci and not extensive transcapsular invasion. Okay? Any other encapsulated follicular tumor is unlikely to metastasize and probably does not merit aggressive therapy. And what is that aggressive therapy? Total thyroidectomy and or radioiodine ablation. So if we look at this now timeline, okay, I was telling you all about 2004 WHO classification. We had, as far as follicular lesions were concerned, and I'm not talking now about those with papillary thyroid-like nuclei. These are just follicular lesions. If you could divide them into minimally invasive and widely invasive. In 2015, the Armed Forces Institute of Pathology, this is not the WHO, had more or less a similar kind of classification. They called something widely invasive, where you had no capsule at all. It was just, the tumor diffusely invading the thyroid gland. But if there was a capsule, it was so minimal that for all practical purposes, it was not a capsule. When it did have a capsule, they had three different ways of classifying it. One, which was the most innocuous, and that is with capsular invasion. Then there were those with limited vascular invasion, according to Hossein, and that was less than 4 vessels, and extensive vascular invasion, that was greater than 4 vessels, okay, 4 or greater than 4. Then in 2017, the WHO obviously took the consensus of many experts and said that there was encapsulated follicular carcinomas were minimally invasive or encapsulated and angio-invasive. The widely invasive ones were widely invasive, they were not encapsulated. So they don't come into our discussion at all. They did not divide up the encapsulated angio-invasive ones into those with limited or more extensive vascular invasion. So this was as far as 2017 was concerned, which is only some 6 years ago. Okay. Now we come to really the most contentious thing, and that was something that Aditya said non-invasive follicular tumor with papillary thyroid nuclei. Okay. And this was what for years we called, right up to 2016, the E, that is encapsulated follicular variant of papillary thyroid carcinoma. Why? Because we believed, and I'm once again telling you this, it did not matter whether the tumor was encapsulated, minimally invasive, or widely invasive, all right, is as long as it had papillary thyroid-like nuclei, whether it was papillary or follicular, in this case, entirely follicular, it was called a papillary thyroid carcinoma. Now, if it was a papillary thyroid carcinoma, okay, then this was going to be treated like a papillary thyroid carcinoma. And numerous thyroidectomies were done for this lesion, which was called, which all of us called, which I called, an encapsulated follicular variant of papillary thyroid carcinoma. Okay, but this was responsible for much of the pathological thyrophobia. Why? Because if it was all like this, we had no problems calling it an EFP-PTC. But what if there were equivocal nuclear features of papillary thyroid carcinoma? If I showed it to 10 people and some said, yeah, I think that this looks like a PTC nuclei, and some people said, no, I don't think it is entirely PTC-like nuclei, or some areas had classical PTC-like nuclei, and many areas did not. So how much is enough? And I don't think we have solved that problem yet. Anyway. Okay, so what was the problem? EFP-PTC was easy to diagnose when the nuclear features of papillary thyroid carcinoma are diffuse and obvious. But look at this thing on the right-hand side. I don't know how many of you would want to call this in the old days, EFP-PTC. There's no nuclear overlapping. Yes, there's nuclear clearing. There is no nuclear grooving. And I don't think that every part of this tumor, there are many areas over here. This was just one area that was that showed this. Didn't have the. In other words, this looked like an adenoma, but it had a capsule. It had everything. So what is it? What should we call this particular thing? And a lot of people wrestled with this problem. Why? Because the majority had an excellent prognosis. Nothing happened to these patients. Okay, and the few that actually had late systemic metastasis actually had angioinvasion. So the question was, are these truly follicular variants of papillary thyroid carcinoma? And we had to deal with surgeons who would do a total thyroidectomy because of the word carcinoma. They still do, many of them. And when you sent it to an expert, the expert's opinion was often at variance. And I know that if I wanted an expert opinion to agree with me, then I sent it to those people who didn't believe in the EFP-PTC. Okay, so you could choose an expert to agree with you, as the case may be. I'm not joking. It usually used to happen. So what could we call these kind of lesions? Should we call it an encapsulated follicular variant of papillary thyroid carcinoma because it showed some features that could be seen in papillary thyroid carcinoma? Should we call it a follicular adenoma with some nuclear features of papillary thyroid carcinoma? Possible. Or should we admit our ignorance or our inability to make a decision and say, I don't know whether this is a follicular adenoma or a follicular variant of papillary thyroid carcinoma? Or should we invent a name? And I don't know, what would you do, Deepak?
Yes, ma'am.
What would you do? Which of these 4 options would you take? I think, you know what? They invented a name. I'm telling you. Now they invented a name. And they invented a name when they were studying all the numerous different lesions that occurred in the thyroids of survivors of the Chernobyl disaster. Does anybody know what is the Chernobyl disaster? Yes? Yes, who said yes? Say who said yes? I did. Who's that? Vishali.
Vishali, yes.
Yes, Vishali. What is the Chernobyl disaster?
There was one big chemical plant mishap and
Chemical plant mishap.
something related to radiation, and a lot of people were
Something related to radiation. Anybody else wants to take that?
It was a nuclear plant in Ukraine.
That's right. It was a nuclear plant in Belarus. It was on the border between Belarus and Ukraine. It was a town called Chernobyl, which had a nuclear plant, which was very poorly maintained. One day there was a disaster in which the plant blew up and you had radiation all over that whole area. Okay, so there were many different kinds of tumors that occurred in the survivors of this disaster, and the thyroid is one organ that is very susceptible to radiation-induced tumors. Okay, so they saw a number of very peculiar lesions in that. Most of them were papillary thyroid carcinomas, and they looked at these encapsulated lesions. They found a number of encapsulated follicular patterned lesions. When there were nuclear features that were classical of papillary thyroid carcinoma and they were obvious, they called them encapsulated papillary thyroid carcinomas. But when it was equivocal in 2 ways. One, 2 ways in the sense that they could see some but not all of the features of papillary thyroid carcinomas, and the lesions were all follicular pattern. There was not a single papilla to be seen in any of these cases. If they had definite capsular or vascular invasion, they didn't know whether they should call it papillary or follicular because the lesions had very indefinite papillary thyroid nuclei. They called them, because there was invasion, they called it well-differentiated carcinoma, not otherwise specified. Okay. When there was questionable capsular or vascular invasion, they called it well-differentiated tumor of uncertain malignant potential. So they invented a name, and that name is still being used. It is well-differentiated tumor of uncertain malignant potential. It's been adopted now, even in the WHO 2022. So they invented a name for those lesions that had some nuclear features of papillary thyroid carcinoma, but it was very equivocal and maybe very focal, right? But the tumors were encapsulated. If there was invasion, then of course that was invasive tumor, but if it was not, then it was called well-differentiated tumor of uncertain malignant potential. Now, this problem was not just with the Chernobyl people. There were lots of issues with how do you tell what is a definite papillary thyroid carcinoma nucleus. Okay, when will you call something a follicular adenoma? When will you call it encapsulated follicular papillary thyroid carcinoma, or sometimes give it some other name? So here were 87 tumors. Some of them very obvious, some of them not so obvious, and they were given to 10 experts, and believe me, these are experts. Okay, now do you see that there were 5, 6, 7, and 8 experts called almost everything, 91% to 100%. It didn't matter. They called them all follicular variants of papillary thyroid carcinoma. The same tumors now. These are not some tumors that they saw and other people saw other tumors, and there were others that's called very few of them follicular variant of papillary thyroid carcinoma. I mean, they call them follicular adenomas and many other different nomenclature. Okay, these of course called very few. These other experts called less. I'm sorry, they called very few of them follicular variants of papillary thyroid. These called even less follicular variants of papillary thyroid carcinoma. Okay, so even experts could not agree. So then people said, we have to have very strict criteria. And the strict criteria, there was Chan who came up with the strict criteria in 2002. I don't think anybody really applies them. He said, look for whatever we said, oval crowding of nuclei, they should be large, they should be pale, they should have all those grooves, and the entire lesion should show the nuclear grooving, etc. And if some of these were missing, then you look for abortive papillary, etc., etc. All right, you have strict criteria. Now apply the the strict criteria. And once again, there were these experts. There were 6 experts this time, and there were 15 lesions that they had to look at. And I will just show you expert number 5. Every single one was called follicular variant of papillary thyroid carcinoma. Expert number 3, similar, except for one which he called FEP. I'm not going to say he or she, I know who the person is. Called it a follicular adenoma. And here, expert number 6, just 2 were called follicular variant of papillary thyroid carcinoma. So what do you think is the real problem over here? The real problem over here is that people, it is a difficult area, and you may be an expert, but then you have your own biases. So if experts can have these biases, then what do people in the real world like I do? And as I told you, we have to then wonder, what is the significance of this thing? Whether we call something a follicular adenoma or we call it an encapsulated variant of papillary thyroid carcinoma. Okay, the experts did not even agree when they got out on the one day they got out of this side of the bed or that side of the bed. They didn't even agree. There was not even intra-observer variation, except for that one guy who called everything papillary thyroid carcinoma. Okay, yeah. So then sooner or later, people went back and they asked if we had called these things encapsulated follicular variants of papillary thyroid carcinoma, and what would have changed? So they went back and reviewed all their follicular neoplasms, and they when I say upgraded, they changed the diagnosis from benign to malignant in 12% of cases. Okay, from 36% to 48%. And you saw that there were no clinical ramifications in patients with the changed diagnosis, which means what? That nothing happened to those patients. So the question is there such a thing really as encapsulated follicular variant of papillary thyroid carcinoma? And then came, I think, the most definitive paper, which was immediately after that. There was the paper that said that experts were not agreeing with one another, and it said something very important. It said that there are 2 variants of follicular variant of papillary thyroid carcinoma. One is infiltrative and diffuse. It is a non-encapsulated variant. The other one is an encapsulated form. And the encapsulated variants of papillary thyroid carcinoma did not develop metastasis or recurrences. The infiltrative ones behaved. They were all follicular. They were follicular variants of papillary thyroid carcinoma because they had papillary thyroid carcinoma nuclei, but they behaved like classic papillary carcinomas with metastatic lymph node patterns and invasive growth. And so they came to the conclusion that the encapsulated, and I hope you realize that we're talking about the encapsulated variants today. We're not talking follicular patterned lesions. We're not talking about all of thyroid carcinomas. Encapsulated follicular patterned tumors with papillary thyroid nuclei were close to the follicular thyroid adenomas and encapsulated follicular minimally invasive follicular thyroid carcinoma. So the first time there was some sense that was now being made of these tumors that had papillary thyroid carcinoma nuclei and were follicular. Okay, so the question therefore was being asked. Certainly I was asking it: is encapsulated follicular variant papillary thyroid carcinoma truly a papillary carcinoma? And it did not behave like a papillary thyroid carcinoma. We just showed in the previous paper, it was shown that it did not metastasize. It did not behave like a papillary thyroid carcinoma. Its molecular profile, moreover, was like that of follicular neoplasms. It never showed a BRAF rearrangement. It had no RET PTC arrangements, because that's the other rearrangement that is found in papillary thyroid carcinoma, and it had RAS mutations that were similar to follicular adenoma and minimally invasive follicular thyroid carcinoma. So we're now beginning to understand that papillary thyroid carcinoma nuclei have to be used very judiciously when we want to call something a papillary thyroid carcinoma. It is perfectly okay to use it for diffuse infiltrative lesions, albeit that they are follicular, but we should try not to use it or try to understand what it means in an encapsulated follicular patterned lesion. Okay? So we have this follicular variant of papillary thyroid carcinoma. It exists. When it is diffuse, it behaves like classical papillary thyroid carcinoma. When it is encapsulated and non-invasive, then it behaves like a follicular adenoma. That became very clear after the numerous papers came out. Okay? Now, so by the time it was 2015, I had certain questions about this whole thing of encapsulated follicular variant of papillary thyroid carcinoma. And what were my questions? My questions were this: if an encapsulated follicular variant of papillary thyroid carcinoma, which now we are calling NIFTP, is more closely related to follicular adenoma or minimally invasive follicular thyroid carcinoma, should not the criteria for defining benign versus malignant be the same as used for follicular neoplasms, right? And we should be calling them benign if they are in a non-invasive, and we should be calling them adenomas, and we should be calling them minimally invasive with and without angioinvasion. I was almost clear on these points. Then, should the definition of follicular thyroid neoplasm always remain one by exclusion? Why should it be? If it should not be by exclusion, because there's some of these tumors that have papillary thyroid nuclei are behaving exactly like their follicular adenoma counterparts. Then, all right, so if you don't believe that, then should the diagnosis of encapsulated follicular lesions incorporate molecular profiling, which is a little bit too far-fetched, because not only is it expensive, it's not available all over. And finally, the question that I have been asking all along: does it matter? And if so, when does it matter? And I think this is encapsulated best in a quote that was from Julian Huxley's lecture at Memorial in 1950. Julian Huxley was the scientific brother. I don't think that scientific is the right word, but of Aldous Huxley, the great writer who wrote 1984. All right. So what did he say? He said cancer must be defined in terms of what the tumor cells do, not what they look like. And what were we defining a cancer as? It looks like it has the nuclei of papillary thyroid carcinoma, therefore we should call it a papillary thyroid carcinoma. Yeah, and he said that it's in terms of what the tumor cells do, not what they look like. Otherwise, the term ceases to have biological meaning. So in 2015, okay, I made a little diagram, and I presented this diagram at a lecture that I gave in Amrita. Okay, and I said that for encapsulated follicular pattern lesions, neoplasms, you can have three groups of tumors. One, which has the nuclear features of papillary, in which the nuclear features of papillary thyroid carcinoma are absent, so that we know, and we've been seeing it for so many years. If it's non-invasive, we call it a follicular adenoma. If it is invasive, without angioinvasion, we call it minimally invasive follicular carcinoma. I believe that if you have angioinvasion, it is a frank follicular carcinoma. Okay, and then you had the next group of cases, nuclear features of papillary carcinoma are present. In those days, we had no choice except to call this the encapsulated follicular variant of papillary thyroid carcinoma, although I was extremely uncomfortable with this term. And finally, you had nuclear features of papillary thyroid carcinoma, uncertain or focal, in which case you could call this the well-differentiated thyroid carcinoma, uncertain, malignant, potentially. Okay, but I knew one thing, and that's what I knew. I knew that this thing, all of these lesions in the box, which I had marked in blue, every one of these lesions had very low clinical risk, and that's what I had said at that time. Didn't matter that you called it EFVPTC; these were all encapsulated follicular pattern lesions of low clinical risk. And I know that when I presented this diagram and I spoke about this, there was an uproar amongst the clinicians, because the clinicians said, "What are you saying? We're taking out so many thyroids for EFVPTC." And I said, "What you're doing is a mistake." And that was in 2015, somewhere around November. And see what came out in April 2016. Okay, in 2016, they had a nomenclature revision for what? EFVPTC. The very thing that I said should not be treated like a carcinoma. And they changed the name to non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Okay, NIFTP. And what did they say? Why did they change the name? Because there was growing evidence pointing to the highly indolent behavior of this particular entity that we had been calling encapsulated follicular variant of papillary thyroid carcinoma. And most patients were being treated as if they had conventional thyroid carcinoma. And it was such a breath of fresh air, and certainly I felt vindicated, because I had been saying for years that we are over-treating these patients. Okay? Because I hope that you students are only interested in how to make a diagnosis. I think what you should be also interested in is what is the impact of our diagnoses on what is happening to a patient. The moment we use this word, and we had used this word for so many years, carcinoma, for anything that had papillary thyroid nuclei, and many patients had lost their thyroid glands unnecessarily. Okay, so this was in JAMA 2016. They had defined it. They said it had to have a nuclear score of 2 or 3. In other words, it had to have all or most of the features of papillary thyroid carcinoma, no vascular or capsular invasion, no tumor necrosis, and less than 1% papillary. Okay? So that was their definition. What happened after that? In 2018, they had an update. This is after the 2017 classification, WHO classification, and they said there should be no papillary at all. Now what happens in 2022? They've gone back to saying they're less than 1% papillary. That's the WHO definition. I believe if there are any papillary at all, you have to be careful that this is not a BRAF rearranged tumor. I would be very loath to call something that has got any papillary at all, an NIFTP, unless I'm sure that there is no BRAF mutation. And in routine practice, you cannot really be sure that there is no BRAF mutation, because of the fact that who gets a BRAF on all of these cases. Okay, so now that we have NIFTP, what are the questions that NIFTP has thrown up? Okay, these are the questions. Can the distinction of NIFTP from FVPTC be made on cytology? How do we make diagnoses on cytology? We look for the nuclear features of papillary thyroid carcinoma. Are they there in NIFTP? The answer is yes. So can I make the distinction between nuclear features between NIFTP and FVPTC? The answer is no. You can't do it, right? So this is one big problem with cytological diagnosis. All right. If the absence of invasion, and this is non-invasive, please mark my words. If the absence of invasion is a criterion for the diagnosis of NIFTP, why aren't we calling it a follicular adenoma with papillary thyroid nuclei? We should do. But we're not calling it that. We're calling it a non-invasive follicular tumor, not an adenoma. All right. I believe that it should be called a follicular adenoma because it's got a capsule and the capsule is not invaded. Then what is the definition of an adenoma? Strange, but this is it. Okay. How extensive should the foci with nuclear features of PTC be for the diagnosis of NIFTP? And they're very silent on this. It is not defined. And to me, it doesn't make any difference at all because NIFTP is a RAS mutated lesion with papillary thyroid-like nuclei, and it shouldn't matter because it's going to behave exactly like a follicular adenoma. Okay, so you call it a follicular adenoma or you call it NIFTP, it's not going to make any difference at all. Now, on the other hand, there was a question in the chat box. Okay, somebody asked this question, I saw it come up.
Yes, ma'am.
Term should apply to follicular tumor with papillary thyroid nuclei with capsular or angio invasion. I just want anybody to tell me what should apply. This is a RAS mutated lesion. If it were a follicular adenoma without any papillary thyroid nuclei, you would call it a minimally invasive follicular carcinoma. All right. So now what should you call this? And guess what it has been called? And this is what I call perversity. Okay. See, Tanya says follicular carcinoma. Very good, Tanya, for you. But you know what the WHO has called it? Because the WHO, I feel, has probably sometimes uses is perverse. What has it called it? My answer, it should be minimally invasive or angio-invasive encapsulated follicular thyroid carcinoma with PTC-like nuclei. That is what is logical. Yes, but that's not, logic doesn't work with the WHO. You know what they called it? Just look, they called it invasive encapsulated follicular variant of papillary thyroid carcinoma. Although they have no evidence that it is a papillary thyroid carcinoma, it is not BRAF rearranged, it is RAS mutated, which is exactly like what follicular adenomas otherwise are. So this is perverse. The meaning of the word perverse is that you know that you should not be doing it, but you do it anyway. Okay, so that's what it is. And you know my explanation for all this? My explanation is this: that NIFTP was an entity or a nomenclature that was created to soften the shock to the system that would have inevitably occurred if a malignant diagnosis was changed overnight into a benign one. And imagine the number of litigations that they would have had in America when thousands and thousands of people had their thyroids removed. So for a benign lesion. So they thought that they better not call it a benign lesion and leave it as a tumor so that, you know, the public doesn't get too antsy and start litigating against, pathologists and their surgeons. Okay, but this, I'm telling you, is absolutely perverse. Now somebody look at this and tell me, okay, here is an encapsulated lesion, completely encapsulated. There is frank invasion of its capsule. What is this now? Invasive encapsulated follicular carcinoma with papillary thyroid nuclei, or whatever they're calling it now, IEFVPTC. It doesn't make sense to me, but it is being called so. Okay, and this is the new classification, WHO classification of thyroid neoplasms. I felt again very vindicated because I said that there were tumors of low risk. And lo and behold, here is low risk neoplasms. Okay, and the first low risk neoplasm is NIFTP. Okay, and what irritates me is in the malignant neoplasms, they have invasive encapsulated follicular variant of papillary thyroid carcinoma, which is nothing but NIFTP, which is invading its capsule. It's no longer non-invasive, it is now invasive. Okay, so this is my sort of feeling about this. I feel that this entity, NIFTP, should go into the benign tumors. It is actually a follicular adenoma with papillary thyroid-like nuclei, and I believe that invasive encapsulated follicular variant of papillary carcinoma the name should be changed to invasive encapsulated follicular carcinoma with papillary thyroid nuclei. And I've given you the reasons why I think so. Okay. And this is their own. Baloch is one of the main people who is part of this WHO 2002, and he made a presentation at USCAP, that is the US Canadian Society of Pathology. And look at this. These are the categories with their, you have tumors with RAS mutations. Okay. Follicular adenoma has RAS mutations up to 20%. Follicular tumor with uncertain malignant potential, those are the ones where you cannot make out whether there is invasion of the capsule or not, or there is questionable invasion. That is up to 20%. The same thing for well-differentiated tumor, where you can't make out whether our nuclear features are equivocal, etc. 20%. Just look at NIFTP. All right, up to 60% of them have RAS mutations, much more than any of these benign tumors. It's a RAS mutated tumor. Okay, and look at what they are calling follicular variant of papillary thyroid tumor. It's more or less the same, 70%. But why are you calling it a papillary thyroid tumor when papillary thyroid tumors should have BRAF, RET, NTRK, or V603 mutations? Okay, and this tumor, which they are calling follicular variant of papillary thyroid carcinoma, is extremely rare to get any of these mutations. It's absolutely infrequent, and it is absent in NIFTP. So why are we calling these things papillary thyroid carcinomas, except that we want to be perverse? Okay, so please understand that NIFTP is related to follicular adenomas and follicular thyroid carcinomas. They are not related to papillary thyroid carcinomas. For years, we believed that they were because they had papillary thyroid nuclei. Now they only share papillary thyroid nuclei, and they are entirely follicular with papillary tumors, and they have RAS mutations. So they have no mutations that which are identified in true papillary thyroid carcinomas. So what do they share with papillary thyroid carcinomas? The fact that they have papillary thyroid nuclei. Nothing else do they share with papillary thyroid carcinomas. Okay, so please remember that. All right. So now if I had to sort of draw my whole diagram, I think I can skip that. So what would I do? I would have the same diagram, except when nuclear features of papillary carcinoma are present, I am no longer obliged to call something an EFVPTC, and I do not call it that. Okay. Nowadays, NIFTP, or I would prefer to call it a follicular adenoma with papillary thyroid nuclei, because that's what I believe it is. If it has invasion, I would call it an invasive encapsulated follicular carcinoma with papillary thyroid nuclei, because it has RAS mutations. Okay, so the box is once again there, and all of these, I believe, are encapsulated follicular pattern lesions of low clinical risk. I called it that in 2015, and I'm glad that the WHO has actually called it that, except that this lesion they have not put into the low malignant potential, and I don't understand why, unless it has angio invasion. All right, so once again, there's a lot of thyrophobia, which I think we should remove, because I don't think that it's necessary. I hope that I forget now who it is who came from Tata Memorial Hospital as the to be a chairperson. She can tell you more about risk adapted therapy. I believe that this question of lobectomy versus total thyroidectomy is more or less solved, because if you use risk adapted management based on age, size, extrathyroidal extension, metastasis, and the tumor type, you would be able to deal with this problem. And I think pathologists would be more comfortable realizing that a carcinoma does not always mandate a total thyroidectomy. Okay, I'll leave you with this. This is differentiated thyroid carcinoma, the staging, and the 8th edition of the AJCC. And all of these that I have outlined in blue are those that require a lobectomy, despite the fact that, remember, this is differentiated thyroid carcinoma. This is not about adenomas, etc. And there is a whole lot of these tumors that do not require a total thyroidectomy. Okay, so we need to know how these patients are actually treated. So what is my message? Do not obsess over capsular invasion or nuclear features of an encapsulated entirely follicular pattern lesion, because they are all follicular neoplasms of low clinical risk, including your NIFTP and the NIFTPs that are so-called NIFTPs that are capsulo-invasive. Okay, angio-invasion is the main thing that you should be looking for. I really don't worry much about capsular invasion. Okay, angio-invasion is of great clinical significance, whether or not you have the nuclear features of papillary thyroid carcinoma present. You see angio-invasion, and it must be highlighted so that the appropriate management can be done. And I think that the rapport with clinicians is important, especially in the era of risk-adapted therapy. I think I finished now, so I will take questions. And first, I will ask the chairpersons to make their comments. So Ranu, would you please? I'll just stop sharing. Okay, and then maybe, yeah.
Take up the questions, ma'am.
No, I think that maybe we should ask Dr. Srivani to make some comments. And it was, the clinician from Tata Hospital. Has she joined? Did she join?
Ma'am is not there.
Not joined. All right, Dr. Srivani, would you like to say something?
Yes, ma'am.
I think you're muted. Yes.
Am I audible, ma'am?
Yes, you're audible, please.
Yeah. Thank you for the very elaborate lecture on this thyroid neoplasms, ma'am. As usual, you brought clarity to the various aspects of thyroid lesions, the classifications, the older and new ones. And as far as I work in a tertiary center, but this being a government setup, we do not have the molecular pathology facilities over here. But yes, as you said, we do face all these challenges which you have mentioned while reporting thyroid, about the capsular invasion, vascular invasion, and sometimes the extrathyroidal invasion, and all these. So with your vast experience, you brought so much of clarity to the follicular patterned lesions with papillary thyroid like nuclei. And I think we should really keep all these your experience in view while reporting the next thyroid lesions. And we at our center, what I have noticed is we are getting more and more of these follicular patterned lesions as compared to the frank papillary thyroid neoplasms. And many of them do have a mix of the follicular pattern with a minimal foci of papillary architecture. And yes, you were very extensive, and we have to really keep all these in view.
No, I take a point, Shivani. The issue is nobody does ERAF unless somebody is doing, maybe at our hospital, even there it's not being done on a regular basis. And I tell you that it is not worth doing this. Okay, you were very right that you're getting a lot of follicular pattern lesions, and you're probably getting them in an encapsulated form. The reason for this is that people are being investigated for a whole lot of other problems, but they get CT scans, PET scans, and ultrasounds where these incidentalomas in the thyroid are being picked up. I honestly tell you that PET scans pick up so many nodules in the thyroid, and thyroid scans are being done so much these days. And really, what we're picking up are these centimeter nodules in the thyroid, which after a certain age, after FNAC, and FNACs are called indeterminate, etc., and somebody goes and takes out, does a lobectomy. So it's happening. These are incidentalomas that are being removed. But what is another trend that is happening is that we are moving, India in particular is moving from a goitrous country to a non-goitrous country. We used to have a lot of goiters because of the sub-Himalayan belt in particular had a lot of goiters. Why? Because there was very little iodine in the salt, in rock salt. Wherever you have sea salt, there is a lot of iodine. But there was the government took a decision many years ago to hydrogenate salt, and as a result of which, goitrous disease has gone down, and papillary thyroid carcinoma is now rising in many areas of this country. I never used to see so many papillary thyroid carcinomas as I'm seeing now. Okay, and those of who practice particularly in the south are going to see a lot of papillary thyroid carcinomas. There is also some evidence that papillary thyroid carcinoma may be related to over-iodination of salt. For whatever reasons, we're seeing a lot more papillary thyroid carcinomas that we used to once upon a time. So on the one hand, we're seeing incidentalomas, and on the other hand, we're seeing an increase in papillary thyroid carcinomas. But like I said, yes, we need to know the criteria for invasion of the capsule. Yes, we need to know the criteria for papillary thyroid carcinoma nuclei, but we should not obsess over any of these unless the tumor is frankly invasive. Then it is going to behave like a papillary thyroid carcinoma. But if it is encapsulated, then there is a invasion of the capsule, or even angio-invasion in an encapsulated lesion. That lesion is a RAS mutated lesion. We don't go into RAS, but we know that this is a RAS mutated lesion, and there is no reason to call that an invasive encapsulated follicular variant of papillary thyroid carcinoma. It is not. It is related to the NIFTP, which is a RAS mutated lesion. That's basically what I wanted to say.
One more question I wanted to ask you.
Yes, please.
Because we have been seeing these tumors in maybe a bimodal distribution of age, where the younger patients have more papillary carcinomas, and we usually see more than 40 years or 50 years follicular. But now, what is your experience after renaming these tumors as follicular variant of PTC?
Well, the number of EFE-PTCs has crashed because everybody now knows that they are NIFTPs. Okay, so there were huge numbers of encapsulated follicular variants of papillary thyroid carcinoma which used to come in consultation. Most of them I used to downplay and call them follicular adenomas because I didn't want surgeons to take out their thyroids, and I have not regretted it. Okay, if they were encapsulated, I didn't worry about it. But yes, there were huge numbers of papillary thyroid carcinomas, not just here; they were there in the West as well. When people were calling these lesions encapsulated follicular variant of papillary thyroid carcinoma, that has come down drastically after the nomenclature of NIFTP has been adopted. Okay, so that's there. The older people who are sort of 50, 60 or thereabouts, they probably grew up in an era where they didn't have iodination of salt, and in such cases, there's still the follicular carcinomas are still winding their way through that cohort or that population. So that is probably the reason why you have that distribution. But there are a whole lot of young people. You have to be if you have papillary thyroid carcinoma occurring in a really young population, in the teens or early 20s, one should worry about whether this patient has been exposed to radiation, because radiation exposure in any way, whether they had radiation for some other disease altogether, that radiation exposure produces papillary thyroid carcinomas in young individuals, really young. I'm not talking about patients who are in their late 20s or 30s. I'm talking about teens or in children, and they don't have the BRAF mutation. They have what is known as the RET PTC mutation, and none of them are encapsulated. Okay, I'm just talking now in general. They are invasive, diffuse invasive papillary thyroid carcinomas, and they have the RET PTC rearrangement. The difference between RET PTC rearranged papillary thyroid carcinomas and BRAF rearranged papillary thyroid carcinomas, and please, I'm talking about papillary thyroid carcinomas which are not these encapsulated things at all. So in case anybody's getting a little confused, in the standard papillary thyroid carcinomas which are BRAF rearranged versus those that are RET PTC rearranged, the RET PTC rearranged ones are exquisitely sensitive to radioiodine, really exquisitely sensitive. So when these children present, they often present with bilateral thyroid disease, lymph nodes, sometimes even with metastases in the lungs, and people think, oh, this is stage 4, but they just melt with radioiodine, and their long-term prognosis is excellent. But the ones that I'm not talking about children, I'm talking about RAS PTC, the BRAF mutated papillary thyroid carcinomas, they are relatively radioiodine resistant. That is the real issue with PTCs that are BRAF mutated. So sometimes people are keen to know whether something is BRAF mutated or not, because the response to radioiodine may not be great. That's the situation with BRAF. So the reason for that, God knows, but at one time they talked about sodium iodide symporter. To take iodine into the thyroid cell, there is a protein which is called the sodium iodide symporter. So it takes iodine into the cell. Now this will work for normal iodine, and it also works for radioiodine. So if sodium iodide symporter is low, and there was one time they said that BRAF downregulates sodium iodide symporter. So if there is a BRAF mutation, it downregulates sodium iodide symporter, and therefore iodine cannot be taken into the cell, and radioiodine will also not be taken into the cell, and therefore the results of radioiodine, the effectivity of radioiodine therapy is less. But I don't think that particular association between the two has been proved. It's still a lot of people suspect that it is so, but it hasn't been proved that BRAF mutation downregulates the sodium iodide symporter. Okay, so are there any other questions, Ranu?
Yes, ma'am, we have questions.
So tell me.
Ma'am, do invasive encapsulated follicular variant of papillary thyroid carcinoma metastasize to bones or to lymph nodes?
Invasive? Oh, if it is invasive and it is capsular invasive, it doesn't do anything very much. If it is angio-invasive, it will go to bones.
Ma'am, another question. Can encapsulated follicular variant of papillary thyroid carcinoma show capsular invasion and vascular invasion?
Yes, that's exactly what I was saying. No, so the invasive, what is the question? Say, repeat it.
Ma'am, can encapsulated follicular variant of PTC show both capsular and vascular invasion?
Yes, but of course it can. That's why we call it that. But what I am trying to tell you is that you should be a little careful about using this term invasive follicular variant of encapsulated follicular variant of papillary thyroid carcinoma. You have to understand it as an entity that is related to NIFTP. Okay, so if it is related to NIFTP, why should we call it invasive encapsulated follicular variant of papillary thyroid carcinoma when NIFTP is related to the follicular adenomas? Okay, yes, any encapsulated carcinoma can show you vascular and capsular invasion. That is without a doubt. Yes, somebody, Mukesh.
Now, one more question.
Yes.
Could these cases of questionable invasion be better diagnosed if extensive grossing of tumor was done?
The more grossing that you do, the better anything is done. But when you've done all your grossing, you still have issues to settle. No, is it true invasion or not true invasion? So you can gross and gross.
Madam, good evening.
Yes, Dr. Mukesh.
Madam, my one question is that it is a very.
Are you a pathologist, Dr. Kandare?
Yes, I am a associate professor in Jabalpur Medical College, madam.
Very good, Dr. Kandare. So what's your question?
I have done my MD as well as SRC from BHU.
Yes.
Yes. So, madam, most of the time it is very difficult to identify a capsular invasion. Like that, if a tumor foci is present on the capsule, horizontally, so it's very tough to identify that it is a capsular invasion or not.
Dr. Kandare, I think that I have said that it is very difficult. I'm not suggesting that it is not. But what I told you, and if you have listened to my lecture, I don't think that pure capsular invasion has much significance from the way that the tumor behaves. Okay, so
yes,
we should not obsess over capsular invasion. If you're not happy about calling it capsular invasion, don't call it. But nothing is really going to happen to this patient. These patients are show very indolent behavior, if at all. they will progress or metastasize. Okay, so I don't think that we should obsess. What you should be really worrying about is angioinvasion. And if there is one message that I want to get across to those who are practicing pathologists, please don't obsess over capsular invasion. Please spend your time looking carefully for angioinvasion. And I know that most people
Yes, of
do
course.
not bother to do that. They are obsessed with the capsule, and angioinvasion is often overlooked. So please do that, because angioinvasion is not a good thing to have. It constitutes high risk. And I cannot tell you about risk adaptive therapy. But risk adaptive therapy essentially says that a low risk tumor does not require a total thyroidectomy. And low risk is not based on histology alone.
Yes.
It is based on age. It is based on whether or not there are distant metastasis and a whole lot of different criteria. Yeah, if there is angioinvasion, this gets into a high risk category. Okay, so
And sometimes angioinvasion is also very difficult because
yes, it is, but it is much easier. It's much easier than capsular invasion. That much I can
Yes,
tell
of
you.
course.
Most of us are
Agree,
not paying for it.
Yes, agree, madam. What's happened that floater are coming in between the blood vessels, and like that we.
Then you have to be careful about things like floaters, etc. You have to make certain that this is an endothelial lined embolus. Yes, it has to be an embolus, and it has to be in the capsular vein or outside the capsule. But that is often missed. That much I can tell you. When you go back to things when you're trying to review histology. Ranu, is there any other?
Yes, ma'am. One question from the diagram from Lesion, that how to differentiate the condition E from a dysfunctional nodule outside the follicular adenoma.
E in the diagram. E.
That diagram, yes, ma'am.
No, there is. You mean that there is the carcinoma completely outside?
Yes, ma'am.
It has to look exactly the same. No, it cannot look differently. It just cannot look different. So it has to be exactly looking the same. It is not such a difficult question if you are. It's a theoretical question that has been asked. It is somebody who has no who's not doing or practicing on a regular basis has asked this question. And it's not difficult.
Ma'am, rest is answered.
Rest is answered. Okay, good. If there are no other.
Thank you very much.
Ma'am, I have one question. Is it necessary to mention extensive?
Tell me.
It is necessary to report extensive or minimal angioinvasion?
I think that even one bit of angioinvasion is bad. But if you have a lot of angioinvasion, you should say it. What's the problem?
More than 4.
Okay.
And we have one more question.
Yes.
I also have a question.
Is it better to overdiagnose or underdiagnose in case of questionable invasion?
This is something that you have to discuss with your clinician. As I told you, if you are in the era of risk adapted therapy, over or under diagnosis of invasion is not going to make a difference. So you have to know, you have to talk to your clinician. If you have an old-time clinician who's not using risk adapted therapy and is only going by the word carcinoma, then you have to be very careful, okay, about what you call a minimally invasive follicular carcinoma. I don't have a problem because I work with clinicians who are, who use risk adapted therapy. And if I know that I'm dealing with an old-time clinician, then I have a word with him about what this is all about. So as I said, rapport, my third point was rapport with the clinician is extremely important. So don't think that everything is in the slide in front of you. Okay, yes, you have to make reasonable diagnoses, but the reasonable diagnoses have to be made in the context of the patient, the age, etc., and what the surgeon is going to do. All right.
And my question is, there was one slide which you showed, and in there were two capsules. One capsule which the tumor formed after coming out of the capsule.
Correct.
Thyroid. So
Yes.
how do we distinguish if it has been formed later on, or if it's?
But you can see it, no? You can see that. I showed you that trabeculum over there. That there are no trabeculae in the thyroid. The thyroid is not like a spleen.
Yes.
Okay. So if you have a thick trabeculum, you have to assume that trabeculum was a capsule, no? And now that that capsule has been breached and a new capsule has been formed outside. This you can't do if you have an organ like the spleen where you have trabeculae, but the thyroid is devoid of trabeculae. Yes.
Okay. Yes, ma'am.
Any other questions? I'm glad that the students are asking questions. Any no?
No, ma'am, no questions. No more left.
All right. That's good. Now, somebody says, does minimally invasive, somebody called Ram, does minimally invasive follicular carcinoma mean only capsular invasion? Okay. Well, by and large, it would be, no, it means both capsular and vascular invasion. But when you say minimally invasive carcinoma, it means that there is a capsule. There is very definitely a capsule. You can see the capsule. And that it is invaded either by the capsule is invaded or there is angioinvasion. And you have to mention that you are calling this MIFC by virtue of the fact that it has only capsular invasion or it has angioinvasion. And the angioinvasion is the much more onerous or the much more prognostically important than capsular invasion. So yes, you can use the term for both, but please don't use it as just minimally invasive follicular carcinoma. Minimally invasive follicular carcinoma with capsular invasion, or it is minimally invasive follicular carcinoma with angioinvasion, or both. So it has to be qualified as one or the other. Okay. So the same question goes on: is widely invasive means capsule and lymphovascular invasion? There's really no much lymphovascular invasion, but widely invasive means that you don't even see the capsule. The capsule, if it ever was there, see, a lot of people believe that all follicular tumors begin by having a capsule. That's not true. Why should it happen like that? Yes, we see mostly adenomas and we see invasive encapsulated tumors, but a follicular carcinoma can just arise de novo without a capsule. No? So that is widely invasive follicular carcinoma. That is what is so difficult to distinguish from poorly differentiated thyroid carcinoma. That's the sort of thing. It's just sheets that are growing with follicles in them. So don't believe that all follicular carcinomas must have a capsule. Why should it have a capsule? It's only the encapsulated variants that have a capsule. Okay, so I'm glad that this gentleman Ram has asked that question. Okay, anything?
And sometimes,
Yes, who's asking?
I'm Dr. Suliani.
Doctor?
I'm Shivani.
Oh, no, Dr. Shivani. Yes, sorry.
when we are reporting the thyroids, ma'am, and the radiology said that it is a highly vascular lesion, and in the sections when we find more congested blood vessels along the capsule, and we keep searching for these, but we don't find actual vascular invasion, I feel I'm missing vascular invasion in maybe some other plane.
No, not at all. Look, the thyroid is a very vascular organ anyway. Okay, and you must also remember that congestion in the thyroid can occur from a variety of reasons, and some of them during intraoperative the intraoperative period when the veins are actually being clipped. So sometimes the artery is still pouring blood and the veins have been clipped, and then you get congestion of that organ. This you see even in lymph node excisions. The lymph node is so congested.
Not in the other.
Sorry.
Not in the parenchyma, ma'am. Along the capsule,
Absolutely.
along the
But
nodule, just beside the capsule.
Yeah, but not inside the thyroid. It has to be outside.
No, outside.
Yeah.
Outside.
So
But when there are elongated,
if there are if there is disease inside that, then you should be able to see it inside. And there's no point in getting overly concerned about this. Okay. All right. Anybody else? If not, I think we can now go and have dinner. Yes. Thank you very much. I thank all the students and